Hi everyone, I want to welcome you to the Waxman Strategies Health Practice webinar, where we're going to talk a little bit about what to expect in 2019, especially after a very exciting election cycle. First, let me introduce myself. My name is Christy Martin. I am Senior Vice President at Waxman Strategies, co-leading the health practice, along with one of my colleagues, Jeremy Sharp, who's joining me today. And Waxman Strategies is a mission-driven consulting firm focusing on the areas defining the next generation of global progress and health, technology, and the environment. You may have known that we've already had 2 webinars focusing on technology and the environment that Henry participated in. Today we're going to talk a little bit about health. And so let me first introduce my panel. Sitting next on my left is our chairman, Henry Waxman. Many of you probably already know Henry's long list of accomplishments, and you can read more about his bio on waxmanstrategies.com. But just to give you a little bit of the highlights, he served in the U.S. House of Representatives for 40 years, where he championed many issues in health, including expanding Medicaid, improving Medicare, the Affordable Care Act, creating the generic drug market, and many others. He was chair of the Energy and Commerce Committee. He was also chair of the Government and the Oversight and Government Reform Committee. Henry, thank you so much for joining us.
Thank you.
Next, we have Bill Core. Bill is Senior Advisor here at Waxman Strategies. Bill works with us on a number of issues, including drug pricing, where he was a staffer for Henry when they passed the Hatch-Waxman Act and also the Orphan Drug Act. So Bill's also had senior positions in both the Obama and the Clinton administrations, and he's had numerous positions on the Hill where he's led a lot of the most important health policy issues. So Bill, thank you for being here. And then last but not least is my colleague, Jeremy. Jeremy's a Senior Vice President also here at Waxman Strategies. Jeremy is fighting a cold, but he is working his way through it so he can be here with us. Jeremy held senior positions at HHS and the FDA during the Obama administration, and he also served as a staffer in both the House and the Senate. So with that, we're going to be covering a number of issues today, including drug pricing, healthcare cost, the Affordable Care Act, Medicaid, and tobacco control. There's issues that we also work on that we're not going to be covering today, such as women's health, vulnerable populations, and generally public health and prevention that we would love to talk to you more about at some later point. Near the end of the webinar, we're going to be taking questions live. If you want to submit a question while we're talking for us to contemplate afterwards and talk a little bit about here today, you can submit your questions on Twitter at Team Waxman, or you can email your question at info@waxmanstrategies.com. So with that, let's get started talking about what to expect for 2019. Henry, it's been a little over a month since the elections. What do you think about the election outcome, and what does it have in store for us next year?
Well, the Democrats ran on the issue of health care. They ran on the attacking the Republicans for trying to repeal the Affordable Care Act and leaving people vulnerable to losing their insurance because of pre-existing conditions, or not being able to buy insurance because at one point or other they had a health problem. They ran on high drug prices and high health care costs overall. So I think with this strong campaign issue, the Democrats are going to want to deliver and get some results. Mm-hmm. In order to do that in this Congress, they're going to have to look for bipartisanship, which shouldn't be all that difficult. When we passed the Hatch-Waxman Act and the Orphan Drug Act and the Clean Air Act and a lot of others, we had a divided government. The president was of one party, the Congress, either one or both houses were with the other party, which means you have to look for compromises, look for common ground in order to make some changes. And I think that is something worth pursuing, and I think there's an opening for it. But the interesting thing about this new House of Representatives, there are 91 new members. That's an incredible large number of new members coming to the House, and they're going to have a steep learning curve to catch up. 91 members is even a larger class than the 1974 class that I came in on, the post-Watergate class. But 91 new members is going to make a huge difference, and they're going to have to learn pretty quickly about, especially these health issues, if that's going to be high on the agenda. Well, both parties are going to need to decide what issues in the health area they're going to push and where they're going to make compromise if we get something done. And a lot of that will depend on the leadership, both in the House, Senate, and the committees. And Jeremy, you've been following the lineup of the new leaders. Can you tell us a little bit more what to expect?
Sure, thanks, Henry. So I think one of the most interesting things is you look at the four major committees of jurisdiction in the two chambers, the House Energy and Commerce Committee and the House Ways and Means Committee, and then the Senate Finance Committee and the Senate Health, Education, and Labor and Pensions Committee. And each of those committees, the chairman coming in is someone who has the capacity to be a real deal maker. All four of them are very much in the mainstream of their party's ideology and political positioning. They have various quirks of their own interests and so forth, but none of them are ideologues, and none of them are fit at one extreme or the other extreme of their parties. And all of them have had demonstrated in past years the ability to reach across the aisle. Of course, who I'm talking about here is Frank Pallone is the new chairman of the Energy and Commerce Committee, and Richard Neal is going to be the new chairman of the Ways and Means Committee. Neither of them have been full committee chairman before. This will be a new experience for them, and they will obviously have a learning curve. But they've been ranking members of their committees, and they've had senior roles for many years on their committees. So they're probably very well prepared to do this. In the Senate, Lamar Alexander is returning as the chairman of the Health Committee. He worked carefully across the aisle on a variety of things. He worked on the Affordable Care Act stabilization bill before the politics of the day made that impossible. And Chuck Grassley will take over the gavel at Finance Committee, where he has previously been. He had been the Judiciary Committee chairman, and even from there, he had been pushing some drug pricing legislation. He may be able to do the very same thing here in the Finance Committee, and I think we can expect him to be taking on some of the entrenched industries that will have passion here. Oversight is obviously a big question. Elijah Cummings is taking over your old committee, the Oversight and Government Reform Committee in the House, and he is a dogged investigator, and I think we can expect him to do quite a bit of digging. As you said, he and the others are going to have to make some choices. Are they going to find policy agreement and bipartisan compromises, or are they going to push agendas that set them up better for the next election and for a new administration, if there is one, in 2021 and a differently complected Congress? My guess is they may pursue both of these at once, but we'll have to see. I think it's very interesting to think about what are the oversight opportunities in drug pricing, and maybe Henry, you could tell us a little bit about what you think Chairman Cummings and of course Diana DeGette, who will be the Oversight Subcommittee Chairman, we think, of the Energy and Commerce Committee might pursue, and how they might advance the issue of drug pricing.
Well, both of the oversight people who are chairing the committees, both in the Oversight Committee overall and Diana DeGette, the Oversight Subcommittee of Energy and Commerce, have a strong background in dealing with high drug prices. Oftentimes the oversight responsibilities will lead to legislation, and I think that all the oversight chairs as well as the policy chairs of the committee can work together, care about this issue, and oversight is a way to probe the issue and educate members of the committee and the Congress and the public as to what's going on. When it comes to high drug prices, we want to know why the prices are so high, what's driving them forward, and then to try to figure out what steps can be taken in a divided government. There's no magic solution, but there are things that can be done. Bill's been working on that, and Bill, why don't you talk a little bit about the high drug prices and what possible solutions might be?
Henry,
imposed?
It's hard to believe that it could be 35 years since we worked on the Hatch-Waxman Act and the Orphan Drug Act, but those laws have been badly distorted by the brand name industry behavior. And I think it's going to absolutely make drug pricing a leading issue in this next Congress. The result of these last 35 years has been unprecedented price increases by the industry engaging in certain behaviors. And the question, I think, that's got to be answered by the committees is, which aspects of higher drug prices are they going to be taking on? And I think that the first one, of course, will be anti-competitive behavior by the brand name companies, in which they take steps that delay or block price competition, which is the other half of the Hatch-Waxman legislation. There are things they do like refusing to give samples to generic companies so they can go through the FDA approval process. They pay sometimes the first generic that gets approved by FDA to not go on the market. They have created a web of patents to deter generics from coming on the market. They misuse exclusivity. So the question in my mind is, which aspects of these many different problems that we've found that are driving prices higher are the committee's going to want to take on? We tried to highlight all of the current drivers of drug pricing in our July 2017 report. And I think the issue for the committees will be which ones are they going to start on. But in addition to the anti-competitive behavior, I think there are major questions that this Congress will tackle about how we reimburse for drugs. The federal government could be a much more prudent purchaser. Christy, you've worked at length on this, and I think there's a lot of activity that's going to occur around how we buy drugs. Not just Medicare negotiation, but in many other ways. And also, the generic and biosimilar approval process can be streamlined. And Jeremy, you've been spending a great deal of time while you were at FDA working on these very issues. So the challenge, I think, for the committees is we've got, as has been pointed out, we've got key bipartisan leaders, leaders who are bipartisan supporters of doing something about drug pricing. We've got an administration that continues to talk about doing something about drug pricing. We've got a House now that's going to have as one of its top priorities addressing drug pricing. So there's going to be a great deal of activity. The question is on which issue, but I think that will quickly unfold once the House comes in session and we begin to see bills being introduced. Jeremy, maybe you could talk a little bit about what's happening with trying to streamline the biosimilar and generic approval process, because that obviously gets generics on the market faster, brings down prices.
Sure. So it's obviously whenever you have a discussion about drug pricing in Washington and even outside of Washington, a lot of fingers get pointed at the Food and Drug Administration, and some people take the opportunity to talk about how slow the administration is in getting its work done, or suggesting if you reduce this regulatory process or you did that regulatory process differently, you could get more competition and therefore lower prices. And some people have even had bolder suggestions in that space. And some of those suggestions are good ones, and some of those are a bit fantastic. Commissioner Scott Gottlieb, upon getting confirmed, moved very quickly to identify a number of things that he thought he and the FDA under his leadership could do administratively to make it easier to increase drug competition. He launched his Drug Competition Action Plan last summer. And included in that were proposals that he started rolling out, such as making it, trying to clarify how companies that couldn't get their samples, as you talked about, could bring the issue up with the agency and challenge the brand name companies. He's recently put out some guidance on citizens petitions and how they should not be misused and what the agency will do to address that. He also launched a prioritization policy that would make sure that the agency focused on generic drug applications for products for which there was not enough competition. And these are all really good steps that he's been taking. We have been tracking his announcements and keeping track of his progress. And you and I and everyone at this table knows how hard it is sometimes to get the bureaucracy at FDA and HHS to produce these things, and Gottlieb has been keeping that going. Earlier this year, he announced a biosimilar action plan to take on similar steps with the biosimilar pathway. He's identified a concern that not enough biosimilars are getting approved and FDA is not getting enough applications, and he's putting forward some ideas about how to better standardize some of the information that companies need to provide, better standardize biologic products, which is challenging scientifically, but to make it easier for companies to demonstrate their bioequivalence and biosimilarity to these products. And these are steps that will take some time to implement. I think you will see Congress taking a look at these things and asking him how he's doing, and finding out what further authorities he needs. I imagine there'll be a place for both oversight and legislation, and I think that will be a partnership that will likely lead to some things. I think also, interestingly, the administration in other parts of HHS has taken a leadership role here, and or at least has started to put out their ideas, and Christy might be able to speak to us about that.
I think it's been really interesting since Azar's confirmation hearings. You know, he kind of laid out 4 priorities, and one of those priorities was very clearly drug pricing. And some of them were even related to drug pricing, like healthcare costs and the opioid epidemic. Also have some themes of some of the drug pricing issues threaded through them. But since he's come on board, they've issued a blueprint on how to address drug pricing. The blueprint probably offered up more questions than actual answers, but it was a start. And then this fall, they've been really busy, especially at CMS. You know, a couple of things that I think people are really keeping an eye on and trying to figure out, you know, what will this do? How will this directly impact drug prices? How will it impact patient care? Are some of the demos and the proposals that they have in Medicare. So in particular, you know, in the most recently, we saw them put out a proposed rule that would allow the Part D plans and Medicare Part D to start applying formulary management tools, meaning that prior authorization or step therapy for the 6 protected classes of drugs. This would be a huge change for the program. So I think it'll be interesting to see how people respond to that. The idea would be that the Part D plans could more closely manage those 6 protected classes, and by doing so, they could help to lower cost Medicare spending. We'll see what it does to drug prices. I'm not sure if it'll have much of a direct impact. The other thing I think that's probably gotten more interest around is the Part B demo that they released in November, and it was just an advance notice of proposed rulemaking, but it was an international pricing index model. It included a lot of similar elements to the Part B demo that was proposed by the Obama administration in 2015. And at the end of the day, it's reference pricing, it's price setting, and so it'll be, you know, I think people were really surprised that that's where they went, and that they were willing to be so aggressive. There's a lot of questions about in the details, how does it work? And does it really impact prices? Would you be able to get, it was a mandatory, it's going to be a mandatory model if it's finalized for providers to participate in, but there's a question about, you know, how do you get vendors and manufacturers to participate in it if you're cutting prices almost 40%? So they have a lot to go before they get there. They'll have to do a proposed rule and then a final rulemaking for it. But it is a very interesting concept, and I think, you know, some of those ideas are ideas that Congress is contemplating on both sides. I think it's also, you know, they've made some moves on Medicaid as well, and so one of the things that I think people are also keeping an eye on is CMS approved 2 state plan amendments for value-based purchasing for drugs for Oklahoma and Michigan. And Oklahoma already has a couple of deals they've made on some products. They're not products that are mainstream or well known, but they are higher priced products. And then Michigan's was just approved, so we'll see where they go. But the idea of testing out value-based purchasing in a real life setting in a federal health program is kind of exciting. And so I think the data coming out of that will be really informative. You know, one thing that CMS will need is Congress's help on a few things, though. One of them is the true cliff, the true out-of-pocket threshold for Medicare Part D that actually puts beneficiaries into catastrophic coverage where they have lower cost sharing. Congress will need to take care of that in the first 6 months. So I have a feeling that'll come up, and that may be a vehicle for some other drug pricing reforms. And the other one is fixing the REMS abuses that Bill was mentioning. FDA is taking a couple steps, but some of I think it's a question about whether does that really resolve the issue? Does that really force manufacturers to share the samples? So we'll see. I know we've mentioned a couple of different things that we've put out, and so, you know, we have some blog posts on some of the administration's proposals and issue briefs. Those are all on the Commonwealth Fund website. You can find them under their To The Point blog or in their issue briefs, including the 27 report on the drivers and the root causes of high prescription drug prices, which is on there. It's also on our website at waxmanstrategies.com. And just a reminder, everybody watching, we're going to be taking questions, and you can submit those on Twitter at Team Waxman, or you can send them in by email at info@waxmanstrategies.com. So just to pivot to a new topic that's kind of related. So overall cost of health care is an issue that seems to be constantly people are talking about, but it's a behemoth. And I think people are unsure how do you actually tackle it. And we were talking about one aspect of it with drug pricing. But in terms of healthcare costs, coverage issues, specifically the Affordable Care Act, Henry, you were the architect of the Affordable Care Act. What do you think the future holds for it in 2019?
Well, I was one of the architects, and I was proud to work on the Affordable Care Act because it had as its goal giving people who needed to buy individual insurance, mostly working people who had jobs, but whose employers didn't provide insurance coverage for them. They had to go and buy insurance to keep them from being excluded from buying insurance because of pre-existing conditions. The Affordable Care Act also provided subsidies for low-income people so they could buy insurance either in the exchanges or go into the Medicaid program to get their insurance. Some of the states have been very slow to expand Medicaid, but that's picking up, and I expect even more states will pick up the option to get federal funds to expand their Medicaid program. The Republicans, from the very beginning of the ACA, before we even drafted the bill, said we got to repeal it. They demonized it. They misled a lot of people to fear that there'd be death panels and things like that. And in 2010, they ran against the Affordable Care Act and picked up control of the Congress. And they said they were going to repeal it and replace it. But we never learned what their replacement would be until the last couple years when the Republicans had control of everything. They had the president as a Republican, the Republican Senate, the Republican House. And what they wanted to do was to take away all the protections of the Affordable Care Act, to even change the Medicaid program, which was in law since 1965. It was adopted at the same time Medicare was adopted. They wanted to make it into a block grant and give states less than enough money and let the states tell people no, they couldn't get it covered under Medicaid. It all backfired on them. And this last election, Republicans who voted to repeal the law, including protections from discrimination on pre-existing conditions, a lot of them lost because of it. Well, there's no way they're going to be able to pass a repeal now because there's going to be a Democratic House, and the Democratic House will never go along with that. It won't even be brought up on the floor. Plus, Republicans have been burned, so I don't think they're going to want to pursue that. But the issues that will have to be pursued is how to stabilize the law. There was an attempt on a bipartisan basis to stabilize the law so the insurance companies would want to continue to participate in it. It didn't quite go the way it should have, but now I think that will be an active issue for consideration. And then the overriding issue are healthcare costs. Now, a lot of people don't realize that in the Affordable Care Act, it not only provided people an opportunity for coverage, but it took the whole healthcare system, Medicare, Medicaid, employer-sponsored, as well as individual insurance coverage, and tried to put in incentives for trying things out that would hold down healthcare costs, like the Affordable Care organizations. Try to see if there was some way of organizing the delivery of healthcare that could be less expensive. Now, the Republicans have never been interested in that. Their idea of how to deal with healthcare cost increases is to make the patients pay more. They wanted to even transform, as they call it, transform Medicare into a program where you get a small amount of money and then you buy a private insurance plan. If it costs more because you have pre-existing problems, well, you have to come up with more money or take a lesser plan. And what we need is to hold down healthcare costs overall in the system, make it more efficient, and not just figure out who's going to get stuck with the extra costs. So these are what we'll see on the Affordable Care Act, as well as oversight hearings on how this administration, even with the failure to pass a repeal and replace, how they try to replace the law administratively, and in effect undermining that law. what do you think on healthcare costs? What do you think that they can be done on the healthcare cost side?
You know, Henry, I completely agree, and I think that one of the things that we're going to see is, you know, Idaho, Maine, you mentioned the states that we're going to expand Medicaid. That's going to help immensely. We know that Medicaid expansion does help to mitigate cost increases because we're taking care of people on their daily health needs, not just taking care of them when they have urgent or emergent needs. And I think stabilization of the Affordable Care Act is another step. You know, we're going to have to take a look at the alternative payment models. I think we'll start to see some hearings this year on how well are some of these working. You mentioned the accountable care organizations. We already have some data back from those of where they're working and where they're not. You're seeing CMS and the administration leveraging the Innovation Center Authority, which was part of the Affordable Care Act, to start introducing double-sided risk to hold the accountable care organizations, you know, financially responsible for saving money so that the money is split and there's a shared savings. So it's upside and downside risk. So if they're not managing that population, they're not going to get rewarded. So I think we're going to see a lot of almost like CMS and especially the House Democrats maybe even being on the same page at times at a high level, but maybe having some differences of opinion on the details.
It's interesting to me how Medicaid, which when Medicare was adopted, Medicaid was an afterthought for very poor people. And a lot of people said, well, Medicaid, it doesn't apply to them because they're never going to be on welfare. Well, it was originally a welfare program, except it also, in fact, most of the money for Medicaid paid for long-term care. So even middle-class people who ended up with a stroke and forced into a nursing home paid as long as they could for that very expensive care, but when they ran out of money, they went on Medicaid, and then Medicaid paid for long-term care. But as a result of the Affordable Care Act, Medicaid has become a mainstream insurance program. And so the support for Medicaid is stronger now than ever before. And I think that the Republicans would, not that I think they'll have a chance to do it, but they would go after Medicaid at their peril, because the American people understood Medicaid is a lifesaver for so many people who need health care access.
Yeah, and I think one of the things that was also a common theme for the Affordable Care Act and also as well as Medicaid is the role of prevention in our healthcare system. So if we're going to start saving costs, we really have to change our system around from a sick care system to a well care system. You know, I know that Bill and Jeremy and Henry, you've all committed quite a bit of your career to doing tobacco control work and really thinking, how do we eradicate tobacco use and smoking in our country? CDC reported this summer that youth rates are incredibly high for e-cigarette use. Gottlieb has been talking about the role of flavored e-cigarettes in that epidemic. So Bill, I was just curious, like, what are your thoughts on what's going to happen in tobacco control next year?
You know, a lot of people, starting with Chairman Waxman, but a lot of public health advocates and people around the country have spent decades fighting against tobacco use and trying to stop tobacco addiction. We've made a lot of progress, and I just was looking at the statistics this morning that we're down to 14% adult use, 7.6% high school smoking. This is smoking now. Still sounds high, but we've got work to do. But what's happened recently with flavored e-cigarettes, with, as you mentioned, the 78% increase in 1 year in flavored e-cigarette use, absolutely sets me back. And I think we've got, as a country, have got to come to grips with, and I think we're getting some leadership from FDA in terms of direction, but we absolutely need the Congress to step up and provide new support for making major decisions that stop this epidemic of flavored e-cigarette use among kids before it gets any farther. We took too many years, it took us too many years to do something about combusted tobacco products. And we still got a lot of work to do there. But the idea that we're now going to have a new generation of young people hooked on e-cigarettes, flavored e-cigarettes, means we've got to have an all-hands-on-deck fight right now to do something about that. And Henry, I know you've led this fight for many, many years, and I think we've got some real challenges that we've got to meet now.
In 1994, we held that famous congressional hearing where the tobacco executives held up their hand, promised to tell the truth, and then immediately lied. They said cigarette smoking was not harmful. They never, nicotine was not addictive. They never tried to spike the nicotine to keep people addicted. And of course, they would never go after children. And all that turned out to be lies. But it took us till 2009, from 1994 to 2009, before we finally passed legislation giving the Food and Drug Administration regulatory authority over tobacco. And that regulatory authority was to figure out ways to reduce people smoking, try to get some warning labels, increase the severity of the warning labels. They haven't quite done that yet because of fear of lawsuits, I think, more than anything else. But at the same time, they allowed these e-cigarettes to come on the market and stay on the market, even though they could have been banned completely. And these e-cigarettes have been very successful in getting kids because they have flavors. And a lot of kids think, well, there's no harm. It's not like cigarette smoking. Now, part of the thinking was there's still a large number of people that smoke cigarettes. Maybe they would be able to give up smoking cigarettes if they had an alternative that delivered the nicotine. That's what keeps people smoking. And if they get the nicotine and not all the combustion from a cigarette, it will do less harm. That has been the theory that the FDA has operated. But they've allowed these flavors in the e-cigarettes, and we see this dramatic increase in kids smoking. To me, we've got to figure out how to get out of this situation, because we're seeing smoking rates go down anyway, and now we're seeing kids using nicotine vapes, and they're getting high on nicotine and addicted to nicotine, and we're replacing one addiction with another. So it's a challenge for all those of us who care about this issue in public health to decide, do we take out the flavors? How much more can we restrict the sale of the e-cigarettes? What can we do for those who want to give up smoking? Going into an e-cigarette cannot be the only way to give up smoking. You just look at all the reductions in people who have smoked and gave it up. They didn't go to e-cigarettes. They might have gotten some medical patches and things like that. So we have to ask ourselves, is this the right course that we're taking? Now, in a couple of years, the FDA is going to have to say to the e-cigarette manufacturers, you have to come in and show that there's what is the standard? A public
health benefit.
A public health benefit for having e-cigarettes on the market. They're going to have to come up with data, because FDA has to make its decision based on evidence and science. And if it's working to take cigarettes off the market and replacing it with nicotine, with smokers going to these e-cigarettes, that's a plus. If it means that we're going to have cigarettes and e-cigarettes with the possibility of more kids using both, that's a very strong negative.
Jeremy, you spent some time working on this at FDA.
Just a little bit of time, yes.
Right, yeah.
So I think that's all correct. And I think looking at next year and the new Congress and the current leadership at FDA, I think we need to be looking at what FDA can and will do in this space. A divided Congress is unlikely to take legislative action dramatically, although it's not impossible. But Commissioner Gottlieb has obviously made this a centerpiece of his actions. He surprised everybody last summer when he announced a major nicotine initiative and proposed a rather bold proposal to reduce nicotine to non-addictive levels in combustible products, cigarettes. But he also pushed back those deadlines that you were talking about, Henry, for the e-cigarette companies to submit their data where they could demonstrate that e-cigarettes are useful and help people quit and are not gateway products for young people. Since then, he's been very aggressive on enforcement activities to try to prevent sales, and has announced a new initiative where he is going to consider restricting the sales of flavored e-cigarettes to adults-only facilities, which may have some impact, but we know from past experience with other with tobacco products that point-of-sale restrictions are sometimes challenging to enforce, and kids find a way. And so one of the questions is, will they go further and actually remove flavored e-cigarettes from the marketplace? They could do that unilaterally with a fairly short window to implement by simply lifting the enforcement discretion that is currently in place. And the current situation is definitely something where we all, there's lots of responsibility to go around, but there are actions that can be taken now, and I think Congress hopefully will press for that kind of action. But
I feel like I have to
yes.
put a pin in this
Yes,
conversation.
absolutely.
You all can talk about this forever. I feel like we could have another whole
Totally.
session on tobacco control and like the role of Congress and the FDA and how to address e-cigarette use and e-cigarette use on the rise. But we have questions. So we actually have one question from the audience. Just a reminder, if you want to submit a question, you can submit it on Twitter at Team Waxman, or you can email it in at info@waxmanstrategies.com. So our first question is, as Henry, getting to what I think everybody's already has their mind on, the 2020 elections, as Dems are thinking about the 2020 election cycle and what healthcare reform looks like. A lot of the candidates were focused this year on Medicare for all, single payer, ACA stabilization, but it was definitely a key theme. Do you think there will be some type of reform for long-term care services as part of the 2020 conversation?
Well, that's certainly an unmet need. Right now, if you're forced into a nursing home, or the alternatives to nursing home, which is home care, or some kind of facility that's not a nursing home, but they'll be sure you get the care that you need. That's very expensive, and Medicaid pays for some of it. But to be eligible for Medicaid, people have to reduce their assets to less than $2,000, and almost all their income has to go to pay for the care that they get. So it's the kind of situation where I wish we would have adopted some insurance program that everybody would pay into. Very few people will actually need the long-term care coverage, but when they need it, it's going to be it's important that they have it. But I thought you were going to ask me where healthcare reform will go, because there are many of the new Democrats that have been elected that are saying what we need is a single-payer system. Some European countries have a single-payer system, although some people here think they have a single-payer system when they have a system where it's private insurance as well as public insurance. In the United States, what we ought to keep our eye on is universal coverage. Everybody ought to have access to health care. And to get access to health care, they need coverage from insurance. I think that we're moving in the direction, especially with the Affordable Care Act, expanding a lot of requirements, not just to the individual insurance, but to the Medicare and Medicaid and employer insurance. It's a way of moving things closer together. And that may lead to a single system, but it doesn't have to. The key thing is to make sure that everybody gets access to care. Over the 40 years I was in Congress, my accomplishments were to get more and more people covered. We expanded Medicaid, which was only a welfare program. We expanded it to children and low-income people, and now Medicaid is coverage for people with low income, even single adults. And we want to give people help to buy insurance. So we got to take the incremental approach, but the goal is to get universal coverage. We have to keep our eye on that ball.
Great point. So we have another question, and this is a long question, so I'm just going to read the end of it because it's way too much. So what does Team Waxman expect to happen to state marketplace coverage, the exchanges, in the coming years, absent any congressional action? And how do you expect current regulatory proposals to impact both premiums and the availability of quality coverage? So I think we talked a little bit about, one of the issues, I think you're going to see some states start to shore up the ACA on their own because they know the value of it. And so, a couple of examples that just come to mind is that, Alaska created their reinsurance program to help stabilize the premiums in their state because they have some unique healthcare issues. Primarily, it's very expensive, time and distance, few providers. They just have a lot of challenges that are unique for where they are. And then I think you've also seen some states start to adopt their own individual mandate. So part of the three-legged stool of the ACA was subsidies, which Henry mentioned, ACA individual mandate, so making sure everybody was in the system, and then ultimately guaranteeing coverage for pre-existing conditions, making sure everybody can get in the system. And so you're seeing states start to adopt their own state laws about individual mandate and protections for pre-existing. I think that'll continue regardless of what happens in Congress. And then we have the federal case in Texas challenging the constitutionality of the pre-existing condition now that Congress has struck down the individual mandate. So I think there'll be a lot of things going on. So Jeremy, I know you probably have some thoughts too.
Well, yeah, and I think that's all correct. I think the other thing that we should be watching is the Trump administration has obviously put out some regulations that allow states to allow plans on their exchanges and in their marketplaces that don't meet the minimum benefit requirements that the Affordable Care Act, the short-term plans, the associated health plans, and so forth. One of the things we're going to have to keep an eye on is how many of those plans get offered, what do they offer, and do they end up being what we all fear they might be when we were working on the Affordable Care Act, which do they end up being junk insurance that where consumers and the government are paying money for premiums, but the benefit coming out isn't worth the money that's been paid. And I suspect that'll be a place where we'll have some oversight and some activity as well.
Well, most of the people that will take those little tiny kind of insurance plans will be people who are healthy, so they're taking a greater risk, and that leaves the sicker people who
With higher
absolutely
premiums.
must have insurance coverage in the pool without the help from everybody paying into the system.
So we have another question about the Medicaid drug rebate program. And so there's been a lot of conversation, I think, in the drug pricing debate on Medicaid best price, how Medicaid purchases drugs. And so Henry, I think we could start with you and then Bill, but do you think Congress will revisit the Medicaid drug rebate program? And if so, do you have any ideas of what they might be thinking about?
I think the biggest thing they ought to address is the fact that with Medicaid, the federal law required the drug companies to give their best price, and you can get a rebate in effect to get to that best price. But then when the Republicans adopted the Medicare drug benefit, rather than leave people who are Medicare and Medicaid in the Medicaid program where we pay a lower amount for their drug coverage, they made them go to Medicare. So a lot of the same people suffering from the same problems, getting the same drugs, suddenly they're paying more for those same drugs, and the government's paying more for those drugs. So we need to address the dual eligible issue. On Medicaid, I'd like to see more ability for states to try out different formularies. I wouldn't want them to have formularies that exclude important drugs that people need, but they could try to figure out some way to get competition between the different drugs that is not allowed because of the federal way the Medicaid program, especially on drug rebates, has been practiced. But these are some things that come to my mind.
Christy, I would just add that I think given the impact of high drug prices, that there's going to be increasing pressure on Congress from states to give them the ability to be innovative. And we'll see where that takes us. They've done some aspects of this, not dealing with reimbursement, but other aspects of it. So I think we're gonna, as Congress begins to do oversight and we really open up all these issues, I think there are gonna be a lot of changes that are gonna be coming.
Yeah. So related to that, and I think an issue that's been a hot topic for some, especially hospitals, has been the 340B program. And especially efforts in this session of Congress to undermine that program and to really restrict that program. So just thinking through, what do you think this Congress in 2019 will do on 340B? Do you think that the current attacks will continue? Do you think it'll be all quiet?
So I think this is an issue where I think there'll be a pretty dramatic change from the last Congress to the next one. Democrats in both the House and the Senate were highly skeptical that this was the high priority drug pricing item, that essentially you have a problem here. If you accept the criticisms of the program, you have a problem here where hospitals are getting discounts for these drugs, and that's causing some sort of incentives and problems in the system. But at the end of the day, the hospitals are getting lower priced drugs, which is actually the goal that many of the policymakers that are now going to be in charge of Congress will be supportive of. So my hunch is that you will not see the House take up legislation on 340B health. It's possible that something could get wrapped into a broader drug pricing package in which the various stakeholders are getting benefits, and for which they might be willing to consider reforms and changes to the 340B program, but I think that's relatively unlikely. The Senate, on the other hand, may be more likely to at least introduce legislation, maybe even mark it up, but it's hard to see where a bipartisan alliance comes together around legislation here.
We'll step back for a minute. 340B was adopted, and I authored it, for the clinics, and then later expanded to the hospitals. And the reason a provider, either a clinic or a hospital, gets a 340B discount for the drugs is because they serve a lot of low-income patients. And so because they serve a lot of low-income patients, giving them a discount may mean the drug companies don't get the highest possible price that they would like to charge, but it means these providers of care can reach more low-income people to provide other services in addition to the lower priced drugs. So there's very strong support for the 340B program. And there was even in the Republican Congress, and there certainly will be even more. A lot of people want to have more transparency. Well, fine, transparency is always good. But the real driver of this issue are the pharmaceutical companies who don't want to have to give a discount. And they'd rather get paid in full, which means sometimes they could just set the price because they have the monopoly over the drug. That just means higher prices, not just for the patient, but for the institutions. And without a 340B program, it would just be devastating to a lot of those who count on that program.
I think that's a good place to end today. So we know that we got some other questions, and we'll do our best to answer the questions on Twitter or via email if you submitted questions to us. And I just want to thank all of you for having a great discussion, but thank everyone for joining us online and for this discussion about talking about 2019 health policy and priorities and what we think is going to happen in the next Congress. Just as a reminder, Waxman Strategies is really focused on the forefront of pushing public health policy issues and really making some strong progress. And if you have any further questions about what we do or how we do it, or are interested in working with us, just send us an email. We'd be happy to talk to you. Thank you.
Thank you, Kristen.
Good,
Thank you,
thank you.
Kristen.
Good job, Kristen.